So this case is not your typical case. This patient's diabetic, and he's had trouble with this recurrent eroding ulcer for how many years now?
Almost 4.
4 years now. So I'd worked with him in the past from a wound care perspective. This has been debrided multiple times. He's had it. So typically when things are recurrent like this, we usually see that there's two main problems. One is either there's an underlying infection, or there's an unloading problem. And medically we talk about unloading where there's something rubbing that's causing this to continue to break down. He's been unloaded at least 4 or 5 times and properly. He's had this debrided 1,000,000 times. He's been on antibiotics 1,000,000 times. So we're now at a stage where we're actually going to be just trying to see if we can re-expose new tissue. So we're going to actually cut all of this down, clean all of this out, so we can irrigate it. He's currently on an antibiotic. We'll be swabbing this and sending that off, even though, again, he's had multiple swabs. But the attempt's going to be made, can we pull this together and give this a chance to actually heal? This is not something I would do within the first month, 6 months. This is a chronic case, and this is very unusual. So this is a chronic ulcer that we're trying to actually heal down. So this has been frozen, even though it doesn't have a lot of sensation here, and we're going to be doing all of this excision and then sort of see what we're left with at the end of the day. So again, no pain here when I do that? No. Now, if this was a normal case, I'd tell you, this stuff would all be debrided anyway. See how this is tough and thick tissue? This is all callus. So if he was having a normal debridement done, I'd be cutting most of this out anyway. We're just going to be being a bit more general with it so that we could actually see about taking this out. Can you get me a swab too? I'm going to need a...
Sure.
Yeah, it's probably under there. Doesn't hurt when I do that?
Nope.
Now this has, we've used 2% lidocaine here. This isn't an infected field, so that should work well for him, even though, again, we're also being helped by his underlying medical condition. Nerve supply here, this is the branch of the tibial nerve that supplies here, the medial pudendal nerve. Medial plantaris nerve, sorry. Plantar nerve. So similar to other areas we want to be doing, we want to make sure we're cutting down to where we're through the dermis. Yeah, it's not balanced. The back one is just not so fantastic. So what I want to see here is I want to be exposing healthy basement membrane as much as I can. And that's why we did a wide excision. That's not hurting?
Mm-mm. You bleeding a lot?
No, not too bad, to be honest. No pain there.
Mm-mm.
So when we're doing wound care, we want there to be normal tissue that can migrate towards each other and aggregate so that it's a chance to seal properly. And that's what we want to be achieving here as much as possible. So this is why I'm using the scalpel, just to re-expose this, to make sure it's healthy tissue as best it can be. Now this is what I normally would be doing. Here you can just tell this is callus, this is buildup here. Same thing on this side. And I hope that if we can correct this, that he has less callus formation that develops with this. None of that's hurting at all?
Mm-mm.
Got it, huh? So all this is just callous, dead skin. So what we'll be attempting to do is I'm going to see if we can put some dermal stitches in, how much we can pull that together. And we'll see. And this is a situation where you'll see other procedures where if we have semi-active bleeds, we want to be cauterizing those. This is one situation where you're going to be leading a little bit more towards leaving it oozing a little bit. Diabetics, you want to make sure that we're maintaining blood supply to the actual lesion so we maximize its chance to heal. Should be good. So once I've cleaned that out, just like this, so this is when, if you're going to do a swab and try and capture active bacteria, this is when you want to be doing it. So through this bed here. And the reason why we don't swab pus is just dead cells. And you want something that's going to grow. So even though this seems counterintuitive, with all of your wound lesions, you want to make sure you clean them out as much as possible. And then you send off some kind of sample. Right, buddy, you want to hold pressure on this for me?
Yep. Coming.
So this is 4-0 gut that we're going to be using. Do we have 3-0 by chance?
Could be.
Hold on just a sec, check. If we don't, 4 will be fine, but it's going to be hard pulling this. So there's always a balance when you're using 4-0 gut. So it's an internal stitch, which means that this will dissolve. You know what? Yeah, why don't you? Maybe around there. So dermal stitches, you start from deep and go to superficial, and then on the other side you're going to do the opposite. So the problem is this tissue is so tight and tough, probably because he's had this done so often. But he's bending the needle. Let's see if I can. And the other issue is too, the needle hub's a little bit too angled. So it's flat. So this is, you can see how that bends. So that used to have an elliptical view to it. I'll have to work around that. So what I'm going to try and do is I'm going to try and move from further back and just see if I can capture a little bit of the dermis more posteriorly. See if that'll catch. I think it's too bent. I'm going to definitely need you to pull that tight for me as best you can. Good enough.
You want another one? New one?
We'll see what happens when I put some other ones in. So what I'm going to try and be doing is seeing if this is pulling it a little bit, but not as much as I would have liked.
Yeah.
So I'm going to have to sort of see whether I'm going to do it at the back end here. All I want to do is pull it together a little bit, so then my surface stitches has a better chance of actually taking. So what I think I'll try and do here is I'm going to try and work within the dermis. Just cut that for me. Yeah. So you can see he's just, the tissue's too tight, so he's just bending that continuously. If I could just get one in. Just have that for me. Can you release the needle driver? Open it up. You. There you go. I'm just gonna see if I can stitch that closed. So because those have been so hard, I'm gonna put the 3/0 stitch, the stronger proline stitch on the outside, and see if I can seal that together. Do you have 3/0 there?
Yep. Good. It's locked.
So the smaller the number, when you're talking about suture material, the thicker the actual sutures. You should be okay with that, right?
Okay.
So leave that. Just dab that for me. So here again, because we don't have good dermal stitches, we don't have good apposition, I'm going to be going from both sides as opposed to going straight across, because I want this to slowly pull together. And again, this is a case where I don't worry about the extra bleeding that's going on here. We're either going to capture these blood vessels and tamponade them, or it'll ooze just a little bit, but I want that from a healing perspective anyway. You're feeling fine? And this is definitely a case if you're doing these type of stitches, if you're not doing 3 throws so that this actually locks on itself, you won't be able to do this. If your partner here ever tells you you have thick skin, I don't care what the argument is, she's right. Oh. It's done here. So the nice thing is at least this came together. But what I would tell you is because the internal stitches were so hard and they don't have a lot of strength behind them, I would leave this in a little bit longer than sooner. And this is certainly something we'll track to sort of see how well this heals. Can you grab me some chlorhexidine, please?
Yes.
You're feeling fine?
Oh yeah.
So it's pretty good. Apposition's good. So, so now I just have to give this a chance to sort of see where that takes us. What, you have some type of walking boot at home?
I brought it with me.
Oh, perfect, perfect. So I'd certainly keep that on because we want to minimize the pressure on this specifically, and then we'll see you back probably around the 10-day to 14-day mark and go from there.